So the objectives of this are that we want to take a spirometry that meets the standard. So a normal curve is when someone blows out, that it'll blow up here. Obviously, if someone's hemoptysis, nausea and vomiting, abdominal pain, and pneumothorax, you probably wouldn't know whether someone's got a pneumothorax. So that's your asthma airway, normal airway. If your asthma attack, it becomes red, inflamed, sore, all that coughing out. and then drop down with the volume. So we're going to focus on this one. This is your volume, which goes up and will go along for about 6 seconds. This is more to do with restricted type diseases, and we'll talk about those and what restriction is, but I really would like us to focus on this one. I'm going to change my pencil to the red dot. Okay, so flow. Flow is how fast you can exhale. So you're trying to get someone to take a big breath in and you want them to be blowing out as fast as they can. This is that flow there. If you think about flow, how fast the air can get out of an airway. And I don't know whether you've heard the concept of obstruction. We'll talk about it again later. But if your airway is narrow and the flow is reduced, you've got some obstruction. And we also look at volume, how much air you can exhale. So how much can you get in? And you may have heard the term restriction. Well, that is about when you haven't got as much volume as you should be in your lungs, therefore your volume is restriction. And we'll talk about those patterns of obstruction and restriction as we go along. But that's what we're measuring, how fast you can get the air out and how much air you can actually get out. So we're measuring how wide your airways are and how much volume you've got in your lungs. Okay. So why are we going to do that? And I said to you before, you know, in primary care, we get people come in and they're a bit breathless and they've been coughing, and you know they can get a diagnosis of COPD because they've been smoking or whatever, and we start them on inhaled corticosteroids. But what we've got to think about is it really a respiratory condition or not? You know, someone can, as you know, and you will know these patients really well. You see them, they come in all the time. All of a sudden, Mrs. Jones is coming in and she's coughing, and she tells you, you know, I'm much short of breath over the last few weeks, and I've got a cough. You might have a locum doctor who's trying to tell you she's got COPD because she's a big smoker. Well, you might actually have heart failure, or she could have GORS, which is gastroesophageal reflux disease, essentially reflux. But those things often get mixed up, and I've seen people send in to see respiratory consultants without spirometry who are actually in heart failure. So, you know, it's a good way to be able to do a breathing test and say, okay, is there narrowing of the airways? Is there restriction of volume? Is this truly a respiratory problem, or could it be something else? Because there are differentials that have the same types of symptoms. Okay, so we want to measure the effect of disease on a lung. And again, now with that flow chart that you've got, so when you've done a spirometry, it tells you then that you can have a look at the severity of obstruction, so the severity of narrowing of airways for asthma, which you might be using for when someone's having an exacerbation. You want to know, should they be down to hospital? Do I want to start them on prednisone? Or is it just a mild attack and we need to check out whether they really are taking the treatment that they should have been taking? With COPD, you can measure is there lung decline, or what level of disease have they actually got? Is it mild, moderate, or severe? And that will dictate what kind of treatments people are veered towards, and whether you really want to be starting to push things like pulmonary rehab, or looking at are they going to need home oxygen? You know, if there's really quite severe disease, you want to be bringing in every kind of treatment you can. And if they're declining quickly, why are they declining quickly? Is there something else going on? Okay, so we've talked about the effect of disease. I've already talked about that mild, moderate and severe. And also we can screen people. So you're probably often asked to screen people who are smokers. Not all smokers have COPD. I see a lot of people who've been on inhalers or who have started on inhalers while they're in hospital, and I'm asked to go and talk to them about their new medications. I do a spirometry and it's normal. If they don't have obstruction on their spirometry, they can't have a chronic obstructive pulmonary disease, which is COPD. So then we're looking at things like occupational risk factors. So you've got bakers. There's a phenomenon called baker's dust, where they get hypersensitive airways. Obviously, things like mining would be more at risk of certain things. and you've got recreational type risk factors, you might take in someone who's got birds, might end up with, I'm going to get rid of that dot, it's flying around everywhere now. Birds, so you end up with an allergic alveolitis sometimes, so they can end up with pneumonia in the lower lobes in the alveoli. So also we might want to have a look at assessing a patient's response to an intervention. So you might start someone on an inhaler, or the doctor start them on an inhaler. You're the one who's asked to talk to them about why they should be taking it. You might be able to show a positive response to that, especially things like Ventolin, and we'll talk about that with reversibility. If you've got asthmatics or who show good reversibility to Ventolin, you want to preserve that reversibility, and you want to be using some sort of preventer to stop the allergic response and stop that smooth muscle being irritated all the time, because if it is, it's going to end up as a chronic obstructive disease and they'll end up with COPD. And other things like pulmonary rehab, they use that is a validated tool to see is the pulmonary rehab working. They do get small increases. I mean, to be honest, I think it's probably more beneficial to really focus on the symptoms and their quality of life. But also with asthmatics, they don't want to be taking 2 puffs of something every day if they feel well. Maybe they don't need to. Maybe we can check the spirometry, drop back the preventers to the lowest dose we can. That is what the guidelines are. Maybe then, we can drop them down, say, yeah, your spirometry is okay. You're not symptomatic. You're not using Ventolin more than 3 times a week. So this is the dose that we need. So we can use it to actually titrate your medications up and down. So why wouldn't you do it? You don't want to be doing it on anyone who's had recent surgery on their eye, abdomen or thoracic for obvious reasons. You don't really want to be increasing pressures in any of those areas because you could cause damage. I once was asked to do a spirometry on a lady who had been out of ICU 4 days, who had a dehisced abdominal wound, and they wanted to do spirometry to go back into surgery. For me a coward, but I didn't really think it was a very good idea, especially considering that the abdomen was packed with sponges. I hadn't even closed. Also, you don't want to do anyone who's been unstable cardiovascular-wise with severe hypertension. By that we mean sort of 120 on 200. You want to be sorting that out before you're doing anything realistically. Recent MI within a month, unstable angina. Obviously, getting someone to take a deep breath and really blow out. You might make changes within their vascular system, and you don't want to be aggravating any underlying diseases. So your patients really need to be stable, unless, of course, you're trying to assess the severity of an asthma attack. And that is a gold standard spirometry. For that, we'll talk about that in a bit. If someone can't do spirometry, they should be going to hospital. Obviously, someone's hemoptysis, nausea and vomiting, abdominal pain, and pneumothorax, you probably wouldn't know whether someone's got a pneumothorax, but be warned, don't do spirometry on anyone who is all of a sudden short of breath and has got a lot of pain, especially if they are a young, tall, skinny male, before someone has done an X-ray. Because we have had a case where someone was, pretty much bullied into doing one, and they did have a pneumothorax and it made it worse. And, your symptoms for that are sudden onset, and they're in quite a lot of pain, and it does tend to affect quite a lot of those young males. Pregnancy, more so first and third trimester, and people who've got incompetent cervixes. If you wanted to do it with pregnancy, is it going to change your treatment? We treat asthmatic pregnant women exactly the same if they're pregnant or they're not. The side effects or the damage that you would do by undertreating asthma while a woman is pregnant is far greater than any side effects of any of the drugs you would give. And dementia, you don't bother wasting your time. As I said before, it's not going to be reproducible. You're wasting your time, and it's torture for you, the patient, and the carer. And you're really not going to get anything that is worth any value to out of it. So patient instructions, I'm not sure whether you do this so much in primary care, because you probably don't really know are you going to be doing one or not until the patient's there. But if you do have a choice, it's preferable that they don't have their respiratory medications for the appropriate time before, as in how long that medication will affect how wide their airways are. So with your relievers, you've got your Ventolin, which is a sudden onset, so that works really quickly, lasts for about 4 hours. Your Atrovent, 20-minute onset, lasts about 6 to 8 hours, and your Oxys, which is another fast onset that lasts for 12 hours. But if you have the chance, you don't really want them having these drugs and medications before you do a spirometry to measure how wide their airways are. They're already going to be widened by those medications. The other ones are your preventers. So ideally, now obviously you don't want to tell someone not to take a reliever if they need them, that could save their life. But you know, these preventers are 12-hour drugs. They've got the 12-hour airway openers in them, so ideally 12 hours. And these are anticholinergic type bronchodilators. You want to try to keep them off those for 24 hours, if possible. Okay, any questions from the audience? Please type them in.
Thanks, Sam. While people are typing, there was an earlier question from Tammy, which I think you touched on a little bit then, and that was a query about spirometry being performed for an asthmatic patient before and after medication. So can we just double check the advice around that while people are popping their questions in?
Yeah, so ideally we don't want them to have had those bronchodilators before they have the test, but it is an absolute thing we do want to do for asthma. We do want to give them bronchodilators and then retest them, because if we want to get a diagnosis of asthma, we want to see an increase in their FEV1, which is forced expiratory volume in the first second. We'll talk about that in a minute, and of over 200%. So we're wanting to actually see a specific amount of improvement after taking a bronchodilator to tell us that they've got asthma, basically. But you want to try and do it before. With COPD, you make your diagnosis after they've had bronchodilators. But before you do your baseline test, it would be great if they've not had any medication.
So that's a great lead into Lisa's question, which is about...
Yeah, the no smoking?
Yeah, for 2 hours before doing a spirometry. What are your thoughts about that? Ideally,
yes. However, it doesn't often happen. If somebody's a smoker, you often find that they will come in. There's not a lot of evidence about how much that affects a spirometry, to be honest, but it is more... it does have more effect when you're doing a lung function, because you do a DLCO, which is a gas transfer type test. So if somebody has just had a cigarette, they will be holding a lot more carbon monoxide in their blood, which will affect their gas diffusion. From spirometry, there's not a huge amount of evidence to say that it will throw off your test or make, you know, your diagnosis completely different. However, ideally, your airways, obviously after you've had a cigarette, have been aggravated a little bit, so you prefer not to have it. But it is really difficult to get people to not, and because they get anxious, so what have they done? They have a cigarette before they come in. And there is an element that cigarettes actually do dilate, although they irritate your airways, they actually are a bit of a bronchodilator. It's a bit of a controversial thing.
Okay, that's really helpful. Thanks, Sam. We don't have any other questions at the moment, so happy to move on.
Okay. So preparing the patient, as we've already said, no meds, preferably not after a big meal, just to make it more comfortable in comfy clothes, and definitely sitting on a chair. Don't allow anyone to con you into doing it standing up. I've done it myself and had them slide down the wall. Don't do it. And that, you know, it is in the guidelines that they're supposed to be sitting as well with their feet firmly on the ground. Now this is a picture with a nose peg. I'm not sure if the guidelines are to use nose pegs. However, a lot of patients I find it really uncomfortable and it almost puts them off. You don't lose a huge amount of air out of the nose for spirometry. If you're doing a full lung function test, probably it is a lot more pertinent that you are using one. The thing that is really vital is the filters. Don't use those cardboard filters that have got nothing in the middle of them, or, you know, a minor membrane. Ideally, we really need to have a proper filter that goes down to the, I think it's 0.05 particles, especially in winter and stuff. You don't want to be spreading viruses through a spirometer. So again, I'm not going to tell you what to put into your spirometer. They're all different, and you know, you need to go through the instructions of how to actually use it. But the big thing is you need to be getting the patient to be breathing in as fully as they can. If we're wanting to measure volume, we really need to have a really big breath in and to blow out as fast as they can until their lungs are as empty as possible. So where's my little dot gone? So you get your patient a big breath in and then out. So they're really going for it. And then you're saying, keep going, keep going, keep going, keep going, keep going. Go through about 6 seconds. I try and say 3, 2, 1. If you've got a bar, try and count it down if you can. If you do this yourself or get someone else in the surgery to do it, it is really difficult when you don't know when it's going to stop. And don't tell. Now, for reproducibility, we're going to want, we'll talk about that, but we're going to want to have 3 breaths. Don't tell them you're going to do 3 tests, especially if they have got COPD or something. They're going to hold on to some because they don't really want to empty it all out. So you're doing that. You're getting them to breathe everything out. Some of the complications, that's why you want them sitting down, is you can get breathlessness, syncope. I've not actually seen anyone faint, but I have seen people get very lightheaded and dizzy, and like the guy who slid down the wall after telling me he really needed to stand up. I've never done it again. Coughing, often people will cough. If someone's been coughing, you know, productive sputum for 2 or 3 weeks or over months, if they've got bronchiectasis, you might want to catch a sputum. Have a pot there. Don't waste the opportunity, because the next time you ask them for a sputum, they'll say, I'm not coughing enough. And bronchospasm, so be prepared for someone to have bronchospasm. I'm gathering that you've all got Ventolin around. I have put a picture with a spacer for a reason. There's a lot of controversy over spacers versus nebulizers. We'll talk about that a bit more with the asthma talk. But if you can use Ventolin through a spacer, you are giving someone a far lower dose. One nebulizer is 50 puffs of Ventolin in one dose. The research is showing that 10 to 12 puff virus spacers get your airways as wide as you can. So if you can use that option, obviously a better way to go. So we talked about acceptable results. So you want someone to take that breath in and go straight away. Don't let them wait, because they'll actually lose a bit of the muscle capacity in their lungs. You want it rapid, and you want it to be continuous with no stops and starts, preferably without coughs in the middle or them just stopping. I mean, if someone needs to be coughing, you're going to not quite get to know the full volume, but at least you're going to measure how wide those airways are at that point in time. So these are some examples here. So we've got good, one here. So you've got that breath out. And it goes down there like that. This one you can see the cough, so they've gone cough. Your abrupt stop. There. This one is typical of the person who you tell you're going to do 3, and they'll do the and they'll just keep a bit of effort, and then you've got your full stop. So these ones aren't really acceptable, and this is what you're aiming for in that flow volume. Oh, there we go. So that's not great. That's not great. That's not great. And that's not great. Okay, so we talk about reproducibility. You've probably heard that term. Is it reproducible? Does it meet the standards? Well, it needs to have it needs to be acceptable. So it's an acceptable trace. They're using acceptable technique, and you need 3 of them ideally. there needs to be less than 150 mil variability in their forced vital capacity, which is how much volume they've got, and the FEV1. We'll talk about those in a minute, but you're looking for something that is, you know, 3 that are really similar values together, and that means that's what the person really can do. And you'll find as people do more, they tend to get a bit better at it. It is quite difficult. So those are our definitions. So we've got the FEV1, so forced expiratory volume in 1 second. That's how far you can get your air out in the first second. That tells me how wide your airways are. If I had a door half open and I put 10 people behind it and I put a whip behind them in that first second, I might only get 5 people out because the door's not wide enough. If the door is fully wide, I might get 9 of them out. So that forced expiratory volume tells you how wide those airways are, tells you how obstructed the airways are. That's why people talk about obstruction, the narrowing of the airways. That's what your FEV1 is telling you. Your forced vital capacity, that's how much volume you can get out. So that's telling you about have you got any restriction? Have you got any reduced volume? That's what when we're looking at restrictive type things. Then you've got your FEV1, FCC ratio. So that is the fraction of air exhaled in the first second relative to total volume. What that means is if you got 2 litres into your lungs and you could only get a litre out in the first second, you're only getting 50% out. Generally, 70% is normal. So if that ratio is down below what is either predicted or 70%, there is obstruction. That is something to take note of. If your ratio is down, there's obstruction. If the ratio is not down, there's not obstruction. People with normal ratios don't have COPD. And then we've got this FEV1 forced expiratory flow. You don't need to worry about this very much, but it is interesting to see that sometimes on spirometry, and I'll show you on some of them, that you might have a FEV1 that's relatively normal, a FVC that's relatively normal, but your small airway, so what this means is the flow of air that can come out as the airways get smaller to the bottom, and the one, and this is down, it's saying that the ones at the bottom are starting to narrow. That is an indication of the effects of smoking. So they're starting to, the airways are starting to react to the smoke. And it's a good way of picking up deterioration. So you might have an FEV1 of maybe 79, you might have an FVC of 75, and then this ratio is down at 49. That's showing you that that person is susceptible to cigarette smoking. You can point that out to them, and sometimes that's helpful in encouraging people to stop smoking. So this probably I could have put in earlier, but the predicted normal value. So when you're reading them, this is why you need to be really careful about putting the data into your machines properly. They're all set on, you know, they might be set on Thames, or they might have been put on the European standards, or whatever standards they are put in. That has worked out what is the average for someone of that age, height, sex, ethnic origin, and a little bit of weight. Height, age, and sex are probably the biggest ones. You really need to have an accurate height. Don't let the little old lady tell you how tall she is or give you her driver's license, because she was probably measured when she was 26 and she's now 86, and you'll see a massive difference. Going back to the flows again, we've got a normal flow here. So we've got that whoosh, out, and we can keep going and keep going and keep going and keep going. Here, we've got obstruction. So remember I said FEV1 is about how fast your air can get out in the first second. So this person is trying to get their air out. The airways are narrow. You can hear the, and they've got that scoop. This is the typical COPD person who goes, and you can hear them trying to get the air out. This is restriction. So this is where my flow might come out, but I haven't got all that volume to go. So my flows come out quite quick. I haven't got the scooping. That's where this one is different. There's not that, out it comes, but there's just not the volume. And this one is a bit of a mixed picture in that I've got some coming out, and I've lost volume too. So we'll talk about those and what type of conditions go with those flows. But hopefully that's making a bit of sense. And if you watch when people do this, you'll see these pictures, and then you can imagine that, you know, they can't get the air out. That means their airways are narrow, or they haven't got much volume. That means the volume is restricted. So something's going on in the lung tissue itself. So that's where we talk about obstructive lung disease. So obstruction is narrowing of the airway. So asthma is obstruction of the airways disease, but it is different to COPD in that it is reversible. And I'll just go over that in a second. And then you've got your COPD group, your chronic, which is the long, ongoing, obstructive narrowing of airways, pulmonary lung disease. And within there, you can have emphysema, which is, you know, your smoking diseases, you know, chronic bronchitis, where someone is coughing up phlegm for 3 months of the year for 2 years in a row, where those airways become inflamed and narrow. And then you've got chronic asthma that goes on for a long period of time. So they may or may not have had optimal treatment, and those airways end up where they don't reverse to normal, and that's the difference. So then you've got your restrictive lung diseases. So restrictive, remember, is about forced vital capacity. It's about the flow. So you've got less volume than you should have. So you've got things like your chest wall deformities, so things like scoliosis. You've got neuromuscular diseases, where things that affect the central nervous system, like motor neurons. That just means that the person's stomach and muscles actually can't get open, and they're not going to get the same amount of air in as they should do. You've got diffuse lung disease, such as tumours, interstitial lung diseases. Severe COPD can end up being restrictive as well, because not only have you got narrowing of airways, you've now got destruction of lung tissue as well. And obesity, and late trimester pregnancy, because obviously someone whose diaphragm is pushed up by a baby is never going to get the same amount of air in. So you can't make a diagnosis. And I have seen this. Someone did do a spirometry on someone who's about to give birth, finishing going into labour, and gave her a diagnosis and wanted to follow her up for a restrictive lung disease. The poor woman was pregnant. She couldn't get her air in. As soon as it was redone after she'd given birth, and she was back to normal, funnily enough. With her hair pulling out, but she was normal. Now this is the flow chart. This is the one I've started to use. I had a different one before, but this one really makes sense to me now. So number one, when we're looking at a printout, and we're going to look at some printouts in a minute, is the FEV1 FVC ratio lower than predicted normal, or about 70%. If it's lower, there's obstruction. If it's not, there's not. If your ratio is not below a predicted value, we'll look at how you can find that in a minute, or 70% as per the Asthma Foundation, you don't have restriction. You don't have obstruction. You've got to have narrowing of airways to have obstruction. So this chart can be used. Yes, you've got obstruction. So are we looking at asthma or COPD? We'll talk about how we know the difference between them both. With asthma, we can see, is the asthma with a mild obstruction? Have they been taking the preventer? Do they need to be, the preventers to be changed? Do they need to be titrated up? Is it a moderate obstruction whereby maybe they haven't been taking their medications, or maybe they're having an attack and they might need to start on prednisone? If it's less than 60, you want to be starting to think about what's going on with their pulse, what's going on with their stats. Is this an asthma attack that actually requires them going to hospital? And again, I said, we don't do spirometry in A&E enough. If someone can't do a spirometry, they're in trouble. It might be 50%. That's telling me that their airways are only 50% of what they should be when they're well. That means I need to be treating them. I shouldn't be letting them go home if their airways are less than 50% open of what they should be, especially if they're asthmatic, which means they probably could get worse quite quickly. With COPD, I'm looking at, yes, how bad are they? But COPD is chronic. It doesn't change day to day. And I'm looking at how severe is their disease. And again, you said this tells me what sort of treatment I'm going to look at in the future. If I don't have obstruction, if this ratio is normal, that means the air is getting out at the, at the same as a normal level, let's just say. So that means that person can get their airway out like any other normal person. That means they don't have obstruction. They don't have COPD. They may have asthma, but it's obviously they're not having a flare-up and they're not having an exacerbation. So no, if they don't have the ratio down, if the FVC is less than lower limit, so that means they've got restricted volume as well, and it's a restricted pattern. If it's not, then it's going to be normal. So hopefully that makes a bit of sense, and we'll try and use that to go through the ones that I've got for us to go through. Okay. Any questions?
Okay, thanks, Sam. So while people take a couple of seconds to pop their questions in, because we've covered quite a lot of really important points in the last little block of slides, there was an earlier question that came through around the testing and use of a puffer, and should patients have a full 10 to 12 puffs for a post-Ventolin test. So if you just wanted to have a bit of a chat about that while people are typing, that would be great.
Okay, now that's an interesting question. I've put that up later. When I went through the guidelines, now Catherine's got a good handle on the treatment of asthma here. 10 to 12 puffs is equal in efficacy, so it's equal in its effect on an airways as a full 5 milligram nebulizer. So if someone can hold a spacer, that's going to get your airways as wide as they're going to get. Now, interestingly, in the asthma guidelines for how many puffs you give, it's only 4. Now, I tend to do the 10 to 12, so the full, unless it's contraindicated. So if someone's tachycardic, I wouldn't, or if they've got known heart cardiac type conditions that are affected by beta blockers, or that they're on beta blockers, I don't want to be giving them a beta agonist, which is what Ventolin is. So if they've got, complicated cardiac stuff, I probably might only do 6. But it is an interesting one, and it is very controversial. We still use nebulizers in hospitals. The Cochrane reviews all for the last 10 years, and all the asthma guidelines and Lung Foundation stuff, actually, in Australia, New Zealand and Europe are all advocating for us to use spacers. But, the amount of puffs varies from 6 to 12. And in the asthma guidelines, it's only 4 for reversibility, which is interesting. I probably would go up higher myself still, but why? Where's my evidence? It's an interesting thing.
Okay. There are quite a few comments about patients as obviously the testing is a challenge for them, so they just can't manage it. And that's kind of a lead on to a query around how many times you can actually repeat the spirometry to achieve 3 acceptable results. So Nikki's asking, what the process might be there.
Some of your machines will actually come up patient fatigue. Now, the other thing is to think about is with patients with COPD. So someone who's got chronic obstructive pulmonary disease and it's quite severe, they tend to lose the elasticity in the bottom of their airway, so they get atelectasis. So you are asking them to take in, and some of those patients you'll watch and they purse lip breathe, what they're doing is they're stenting their alveoli open. What you're asking them to do with good spirometry is take a big breath in and completely empty out their lungs. So they're going to need a long time to recover. You need to give them a few minutes at least to recover. Now, depending on the patient themselves, I wouldn't do, 4 or 5 on someone who really is struggling doing it. For an asthmatic, if all I'm wanting to know is how severe is their exacerbation, I'll probably only do one. Because what am I going to gain by doing more? I really just want to see roughly how wide their airways are. If someone's, getting faint-headed or whatever, you might not even get through. You'll be guided by patients having a look at them. And these are probably people that you know in primary care. You've got that luxury that sometimes the patients are familiar to you. I mean, some people just don't want to do it, and there's not much you can do apart from just encourage them to do. But some of the machines will cut out. I think most they go up to is 8, but some of them will actually pick up that you're getting a variation. Remember I said about it being reproducible and it being 150 mils between the highest and lowest for the FEV1 and the FVC. Some of those machines will pick it up that it's dropping and they'll tell you to stop because the patients are fatigued.
Okay, great, thank you. And that actually raises another good question that's come through from Mickey, which is around how young a person or the youngest age you can effectively take a spirometry, particularly as they might be quite anxious.
I think I would have to look this up in the guidelines, which I've actually got here, but I'm pretty sure it's about 7 or 8 years you can do it. But it does really depend on the patient and the parent. Sometimes you'll have a child that's all right, but not a parent who isn't. And some of your 7 and 8-year-olds are really quite cognitively with it. Don't have any problem breathing out when you tell them to. It's really about, can they comprehend that breathing in and blow out fast? Have the same problem with your elderly patients. What I tend to do is demonstrate it. You need to actually show them, take a big breath in, put the mouthpiece in, tight still and blow. And you need to be really fast at blowing out. So you want to really encourage them to go for it. And keep them going. So a lot of it is about how you can explain how to do it. And to be honest, the most effective way I find is to show them. And I might not actually use a mouthpiece, but I might, put my fist up to my mouth and show them how to do it.
Okay, lovely, thank you. Now I'm just conscious of time, so happy to pick up where you left off now. Thanks.
Okay, so here is our bit about obstruction. So if I've done my first spirometry and I can see that my FEV1 and my ratio is less than what it should be, what do I do?
Okay, so we've got options.
Absolutely fantastic. Absolutely, do reversibility testing. But why am I doing reversibility testing? So I want to know, is this actually asthma or is this COPD? So yeah, I've given my bronchodilator, I repeat it after 10 minutes. And that's where the National Asthma Council for 2012, that's an attached document, actually say 4 puffs of salbutamol. I don't think I've ever seen anyone give that little, but I did a assignment on new spaces versus nebulizers, and we're still using nebulizers left, right and centre without any real evidence. So it's quite an interesting concept. So yep, we do it. A positive response is 200 mils and 12% with FEV1. The Australian Thoracic Society and European will actually accept 12% in FVC as well. Needs to be done in a lung lab really, because we can't be that accurate with our spirometry. So you're looking for 200 mils and 12%. That'll come up in the readings. You can find that in the readings once it comes out. If someone's got that response, it's asthma. Someone with COPD might improve 10% and 100 mils. That's going to be significant for them, and that's going to mean that bronchodilators for them do open their airways and should be part of their treatment. So the difference between asthma and COPD, not going to read through this because I'm a bit behind here, But ultimately, asthma is narrowing of the airways, so obstruction of the airways, and it's reversible to normal. So that's your asthma airway, normal airway. With your asthma attack, it becomes red, inflamed, sore, all that coughing. Now, how are you going to get the same amount of air that you can get out of that? That's where the narrowing comes from. That's where the obstruction comes from, and that's where the drop in FEV1, forced expiratory volume in per second, comes from. Then you've got your COPD. Again, we said it is obstruction, but it's not fully reversible. And you can see here that you've got narrowing of airways there. So yeah, we've got obstruction. Sometimes in severe COPD, you've got damaged tissue too. So then you're going to end up with a drop in forced vital capacity, your volume. So you can end up with restriction as well. Severe COPD can be a mixed picture of both obstruction and restriction. Any quick questions? And then I think we get on to reading some spirometry, which is probably what you really want to do.
Okay. Again, just while people are thinking, Lisa's very patiently been waiting for a question, which is around spirometry and the positioning in the person's mouth. So just let me have another look so I make sure that I read it correctly.
Yeah, I can see the question, Lisa, and it depends on the type of spirometer. So some of the spirometries you can breathe in through them, and some you can't, because the filter in them will stop the person getting a full breath. What I tend to do is try to get them to take the big breath in, then put it in their mouth and make sure they've got a tight seal. I think it depends on the machine, and the only way you're going to get a proper whatever answer is out of your machine's instructions. Because some of the filters too, they tell you not to do that. Okay, hopefully that's helpful. All right, so let's have a look at some spirometry, because that's really what you want to have a look at. All right, so these have been split into two slides. So number one, we're looking at the picture. So we're going for that flow volume. On your printout, there's a green line, a brown line, whatever. This is what is normal for that person. This is what is expected for this person of this age, height, race, and sex. So that person is blowing out really pretty well, and they've got really good volume. We could assume that's pretty good. If we're looking at the printout that came out with that, you know how I was telling you about predicted value? Okay, so this is the FVC, so this is their volume, their vital capacity. Now this person, this is the person's measurement too. So, and this is pre. So if you were going to do spirometry, you'd have a pre and a post. But this person has breathed out 5.5 litres. It looks pretty good for a start. But how do I know that? So I go to the reference range is between 4 and 5.9. What is average is 4.9. So this, what the person blew out is measured against what's average. They're 113%. It's well above what's predicted. Anything above 80 is pretty much normal, but you can see what values are there. FEV1, how fast the person can blow their air out. So they've done 104% of what is expected. Anything above 80, again, would be normal, but we can see 3.92. Well, that's right in the middle of there. That's well within what's predicted range. And the ratio, so this is our, have they got any obstruction? Okay, so it's 70%. What is normal is between 67 and 86. There is no obstruction. The FVC is within normal range. It is a normal spirometry. And if we wanted to get clever and look at these lower airways, we could see that they were 2.58, which is within that normal range there. That one's normal. Okay, so the next one. So next one. All right, we've got two. So we've done one blowout. Now we've done the second blowout. Now this looks like it's pretty good. But I don't know unless I look at the numbers. Is this truly asthma, or is this a good response to bronchodilators? So I might have COPD that's got quite a bit reversibility in it. So I need to look at the numbers. And then I get to these numbers. Okay, so first I'm going to this ratio. Right. So I have got some obstruction still going there. Yeah, a little bit of obstruction, only just a bit. Then when I'm going to do my FBC, that's looking pretty normal here. It's within normal ranges, 2.48, 2.98, all within normal ranges. 3, which is before Benson, a little bit lower than normal. Now I've gone back almost up to normal. And I've got a change of 20%. And if I look at my first value of 160, now I've got 191. That's 300 mils and 20%. The reason this person's still got a little bit of obstruction is probably because their treatment's not totally optimized yet, or it's a chronic asthmatic who will end up probably in that chronic obstructive pulmonary disease basket. That's where it gets a bit complicated. But this person's got a good response, 20%, 200 mils is asthma. Let's not make it complicated. And I would treat that as asthma. Okay, so now we've got another one. Same, so we've done it twice. What have I got here? That is a telltale of obstructive chronic obstruction. I've done another one, not much improvement here. So I haven't got much reversibility by the looks of that. So my flow's going up there. Haven't got to what's normal. The volume though, note this keeps going, so this is going to normal. So there's nothing wrong with the amount of air the person can get in or out, it's how fast they can get them out. So when we look at the numbers then, this is actually as a lung function one. So we'll forget about all of that, but this is someone who's got not very good gas transfer, and that's from the smoking and hanging on to the carbon monoxide. So here we go again. Okay, so we're into the, is there any obstruction? Well, that 39 is definitely not in normal range, nor the 40. And remember with COPD, you make the diagnosis, is it mild, moderate or severe after giving ventilator. So we've definitely got obstruction. What is my FVC, my volume like? So it's 4.5, it's within normal. That's 118%, so that would tell you it's pretty normal, anything above 80. And then you've got your forced expiratory volume in the first second. So we're looking at that after, it's 1.81, it's down. So this is down. If I went to my chart, if you've got, those of you who've got your flow chart in front of you, so this is someone with COPD, yes, they've got obstruction, the ratio's down, the FEV1 is down, it's 64%. So it's between 60 and 80%, above 60, so it's mild obstruction at this point. Interestingly, this person has actually got quite bad gas transfer, but it's mild obstruction. Okay, so now we've got another picture where we're blowing out, not very good. And we haven't got much volume either. We have got a bit of scoping out here, a bit of obstruction. So it looks like this one is a mixed pattern. It's not meeting any of what is predicted, this picture here. And then when you're looking at your ratio, your ratio is normal, but both your FEV1 is down and both your FVC is down. So you've got a bit of a mixed picture there. It's probably more restrictive in that we don't really know how much narrowing there is, but that person is only getting a minuscule amount of air in that they're only getting a litre in and they can only get out 0.7, which is, you know, which is 70% of what they've got in. But that's a bit of a mixed picture there. That was a bit complicated actually. But we needed to see some of your spirometry. Okay, we got any questions from the audience?
Sam, Lisa's wondering where the 150 litres difference comes into it.
That's the definition from the Asthma Council. Millilitres. So the definition for asthma is an increase in FEV1 of 12% and 150 mils. That's it. Yeah.
Okay, so can you tell us then how that translates into what you see, or how you see that difference in the numbers?
Okay, we'll go back to the asthma slide.
Yeah.
I think it's 200 meters. 200 mils for asthma. So just to go back.
It'll be in the guidelines?
Yeah, it's in the guidelines, and I'm pretty sure it's 200 mils. I've got it here in front of me.
Okay, so we sent the links to the guidelines, and we'll make sure that they go out with the presentation as well.
Yeah, there's a whole handbook. The link is to the whole handbook, and that'll tell you medication titrating up and down, how to assess the severity of the asthma, how to diagnose it, the whole lot. That's really good. So where's our pre and post here? Okay, so here we've done one before. So before is 1 litre 600 mils. And after is 1 litre 900 mils. That's 300 mils. So you've got to subtract that from that. And it's telling you, it does the calculation for you. You can't sort of work out the percentages because it takes into other factors. And that's 20%, so that's more than 12. So what they're saying is you've got to have reversibility. If for asthma is a variable condition, you need to have reversibility, and it needs to be of that amount. That's what, you know, all of your standards say for it to be true asthma. You can have chronic pulmonary obstructive disease that has a certain amount of reversibility in it, and that's where it gets a bit difficult. But for it to be true asthma, you've got to have that true reversibility.
Okay, that's great. Thank you. That's much clearer.
Right, where were we? Now we've got to flick through those bits.
Yeah. So I think we're up to thinking about or reviewing what we've learned.
Okay, so spirometry is important, and it does give you an insight into what's going on in someone's lungs. You can use it to try and, you know, to show people. Some people will come in and tell you that Ventolin is doing nothing for them. Well, if it's asthma and it is reversing their airways, then you can tell them that they are not properly controlled. Obviously, if someone tells you that I'm okay, but you can improve their airways by 12% and 200 mils using Ventolin, their airways aren't optimally open, and that often happens with asthmatics. They accept being a bit unwell, and they accept, you know, being a bit wheezy, and they accept waking up a bit at night as that's just part of their asthma. So you can use it for that. You can, and as we said, you know, you can use it to say, is it asthma or is it COPD? So the big thing is obstruction and restriction are the things that you're really thinking about, and they're the things that are thrown around. Obstruction is narrowing of the airway. It's an O. The airway is round, it's narrow. So obstruction is narrowing of the airways. That's your FEV1, forced expiratory volume in 1 second. It's how fast you can get your airway out. Asthma is reversible and COPD is not. And you tend to find that your asthmatics are much more variable. You know, they can be good 1 month and bad the next, whereas COPD is not fully reversible. They can use Ventolin for symptom control, and that's where using the medications comes a bit different. It comes in differently, and we talk about that in the asthma and the COPD talk. But for spirometry, we're trying to differentiate, is this narrowing of the airways reversible or not? And restriction is reduction in volume. If you've got reduction in volume, they need to be referred for further investigation. Why can't this person get all that air in? Have they got a tumour in there? Have they got damage to their lungs? You know, what's going on inside their airway? And I mean, saying that, you can have a bit of loss of volume, as we said before, with severe COPD. you've got that much damage to your lung tissue from the smoking, that the airways, the alveoli sort of fall apart, the elasticity is not there, and that part of the lung becomes pretty much null and void. Now, so we'll go back to the poll. So clear your mind again and just think and just have a look at that now and tell me what sort of pattern do you think that is. Remembering this is what we're aiming for. This is the flow. Have they got normal flow? Have they got normal volume? Fantastic. Hopefully you feel quite confident in that because you've all got it right. Fantastic.
And the answer, I don't know where Lindy's gone for a second, but she might have been on mute, is mixed from an overwhelming majority of people who've answered.
Which is brilliant because we were a little bit not so confident in the beginning. That's fantastic. I'm pretty happy with that. Okay, so next. Okay, so this is the normal trace, this is the flow, and this is the volume. Well done.
And again, everyone's saying
fantastic.
Normal.
Absolutely fantastic.
That's great.
Okay, next. Oh, next. Here we go. Okay. So Bitry is not, so yeah, we've got the flow going out first time and flow the second time. It'd be ideal if that second one was right up there. We can see quite a significant difference there. What's that telling us?
Yeah, everyone's writing.
Brilliant.
Coming up, Trump.
Fantastic. Brilliant.
Yep, unanimous.
Absolutely brilliant. Okay, and the next one, so here we've got that flow coming out, and then we've got the scallop. Remember, listen.
Oh, then what?
You can hear obstruction, and they keep going and keep going and keep going. Flow's okay. Fantastic. That is really. I'm very happy.
Everyone's got it. Yay.
Excellent. That's brilliant. Well done, guys. Hopefully you feel a little bit more confident having a look at those. It's a bit more tricky with the numbers. We could do another chat on that if you want down the track. Look at the predicted. Somewhere on the spirometry printout there are numbers that are normal for that person. Are the numbers you've got within normal range? If the ratio is normal, there's not obstruction. It can't be COPD if there isn't obstruction.
Thank you, Sam, for your time and sharing your knowledge and expertise with us tonight. It's been absolutely fabulous to have you. I know I've learned a lot, and everyone online obviously has as well.